Hi, I'm Essen Zafar, and today we'll talk about the crosswalk between quality improvement and research. In the next hour or so, we'll talk about clinical research and improvement science, with focus on their similarities, differences, and the synergy needed. I will briefly cover various study designs used in research and QI and their overlap, and in the end, we'll talk about navigating the IRB process and publishing QI work. So let's begin. Imagine you just came up with a pill of happiness, and you believe that this pill is going to revolutionize people's behaviors and make them happy. The first question that comes to your mind is what information you need to bring this pill to patients. You need to know the pill is safe to take, how much pill is needed, and how effective it is, and what audience is going to benefit from this pill, and so many other questions that you would like to answer through clinical research. Now, the next challenge is if you prove its effectiveness in a certain population, how can you maximize the benefits of this intervention to all applicable audience? So these two questions are basic differences between research and QI. Of course, improvement science would not be limited to the pill only, rather it would talk about the outcome of happiness. And this pill might be one of the multiple interventions and possibilities that can improve happiness. Now let's go on to real definitions. Clinical research is defined as a systematic intervention, which includes research development, testing, and evaluation designed to contribute to generalizable knowledge. So here the part of generalizable knowledge is important because what you're trying to come up with is an answer that applies everywhere. So here's the basic framework of research. You start with a research question, and then you identify its target population and the phenomenon of interest. What is the outcome of interest you're trying to look for? With that in mind, you then come up with a study plan and have an intended sample size that you would need for proving your point. Based on the study design, there are chances of having random and systematic errors that will give you findings that may be slightly different than the true reality. You identify the measures, you select the intended population, and then you execute the study. And the study execution might actually be different than the plan that you had in the beginning, which is again prone to random and systematic errors. After all this information, you infer the findings from the study to the population at large, and this is now the generalizable knowledge that you have created about this specific intervention. Good clinical research is essential for creating the scientific knowledge we need to progress. The idea here is to develop new knowledge rather than implement it, and the emphasis is on cause and effect relationships of the intervention to the outcomes. There is attention to controlling all sorts of biases so that we can have a clear comparison of the effects of the intervention, with the key question that we are trying to answer being, does this intervention work and how well does it work? Multiple steps are involved in translating discovery into clinical practice. First, we need to establish its clinical efficacy through sound clinical research, and then assess its comparative effectiveness with other interventions and cost effectiveness and so on. All these questions need to be answered through sound clinical research. And we as medical community has gotten really good at it, and there's a lot of research happening. Now take a guess, how many randomized clinical trials are published each year? What do you think? So the answer is 36,000 clinical trials are published every year. That's a lot, 36,000 trials. Now, of course, some of them are small ones and some of them are major practice-defining trials, but there's a lot of this happening and new knowledge is being generated all the time, and we're finding new and effective ways of taking care of things. But the sad reality is that even if you find an effective answer, an effective intervention, it takes years to bring that to practice. It takes about 17 years to bring only 14% of research to practice. How sad is that? Our patients deserve better. Public deserves better. The methods and the tools that we use in clinical research are not designed for implementation and sustained improvement. We need to apply the right tools for the appropriate task. And in words of Dr. Don Berwick, you can't eat soup with a fork. You need the right tools. Multiple studies in the early 2000s have shown that in the US, appropriate care is only delivered about half of the time. Let this sink in. that appropriate care in the US healthcare system is only delivered half of the time. This is true in preventive health, in acute care, and in chronic care. And this is not because of lack of knowledge or not knowing what kind of care is needed. As Dr. Goldman said, even if one knows what needs to happen at the bedside, one does not know at a system level how to achieve that in a safe, efficient, and a sustainable way. This is the gap we are dealing with in our healthcare system. Effective care is not reliably delivered, and our systems are plagued with an enormous amount of unintended variations. Unintended variations would be places where patients end up getting different types of cares not because of their disease condition, rather the system in place. So let's take this example. This is the antibiotic delivery time in patients who are presenting to the ER with sepsis. And all of us know that early antibiotics and timely antibiotics in sepsis are life-saving. But despite knowing that, we can see that among the 40 providers in the ER, the time of antibiotics was from 70 minutes all the way to 300 minutes. Almost 12% of the variability in antibiotic time was attributable to the provider on call. Let's take another example. Here, the COPD readmission rate is presented for different hospitals in the CMS system. And you can see that depending on the hospital the patient goes to, the risk of readmission, which is coming back to the hospital and getting admitted within 30 days, varies from 15% all the way to 28%. We shouldn't accept that. Point being that there is a huge gap that we need to close to get better outcomes and deliver better care. And it's not the lack of research and innovation right now. Rather, the bigger gap is implementing what we know in a reliable way and having a mindset of continuous improvement in our systems, with the goal being that every person who interacts with the health system should get the best possible care as we know from the knowledge we have created or generated through clinical research. And this is precisely the last step in the research translation. It deals with measurement and accountability of the healthcare quality, implementation of interventions and healthcare system redesign, and then scaling and spreading the effective interventions and doing research in finding innovative ways of doing this. So let's look at the definition of improvement science. In typical trials, we take sample from population and control the factors as much as possible. We have inclusion-exclusion criteria, we have extra funds, resources, research coordinators to tightly support all activities. Now, once we get the results, we want to generalize it to all population. But in real life, we know it's not always such a calm lake. Rather, it's a gushing river. The application of interventions in real life are not to only a select people of study protocol. Rather, it's a diverse population. There is no extra resource or funding to implement. The staff is busy with so many other workload and there are competing responsibilities and whatnot. And by now, all of you have experienced that in your project work. So this is where improvement science comes in. It is defined as systematic, data-guided activities designed to bring about immediate positive change in the delivery of the healthcare in particular setting. It's a systematic effort, it's data-guided, and that's where we see that we have worked so hard on being objective in our judgments and our decisions when we are heading towards improvement. And the intent is to get immediate positive change in the system that we are working in. So we take the context into the play rather than ignore the context. So here we try to understand the context, our measurements are ongoing, and our aim is continuous improvement. There's special focus on learning from variations. The interventions are theory and data guided, and we follow a methodology to bring about this change. And we always want to have a foresight towards sustainability and spread. So essentially the key question in improvement science is, how can we continue to improve the outcome in a certain context and beyond? Here are some of the contrasts between improvement and research. The aim in improvement is to improve the processes and the system to deliver better outcomes, whereas in research we are trying to create new generalizable knowledge. The inclusion of participants in improvement is liberal and real life, whereas in research we are a bit more selective in picking up the participants and defining strict inclusion and exclusion criteria. The observability of the test is open, and we learn from experience as we are going through the test right away. Whereas in research, we try to blind it and learn from it afterwards to prevent the bias. In improvement, we embrace the context. We understand the factors that are playing in the context so that we can design interventions based on that. Whereas in research, we try to minimize the biases, minimize the effect of the context on our observation. The sample size in improvement is just enough to help us guide the next step. As you know, in our PDSA tests, we just take enough sample, do enough cycles to help us put a better prediction for the next cycle, to learn from what we have already observed and then adapt and move on to the next one. So we don't wait for large number of sample collection to make a judgment. Whereas in research, we always want to have enough sample size to be able to find the differences. The hypothesis in improvement is always flexible and evolving. As we learn and build new theory, we change our hypothesis and our predictions for the next step. Whereas the research, it's pre and post. You come up with a fixed hypothesis and you see if it worked or not. The testing strategy is sequential versus a large test in research. The core part of improvement analysis is done over time using run charts and control charts, and there is a special attention to separating out the effect of common cause variation from special cause variation. In research, most of it is pre and post testing or comparing two groups using comparative tests and analytics. And the type of data in improvement includes qualitative plus quantitative data. So you want to take the human aspect of change as well. Whereas in research, usually it's the quantitative data and rarely there would be some qualitative input as well. Now take a moment and see in what areas of your clinical domain or your work you can see there is lack of research versus lack of improvement. Take a moment to reflect and share your thoughts. Let me give you an example of my personal experience leveraging QI and research together to improve outcomes. Our objective here is to reduce the COPD-related readmissions and hospital and ER revisits. So the system we were dealing with previously was such that if 100 people present to the ER with COPD exacerbation, 38 would be treated and released from the ER and would go home. 22 of them would be admitted to the ED observation unit for 24 to 36 hours for care, and then they would be either admitted or sent home. And half of them would get admitted and half of them would be sent home. And 40% would be admitted to the hospital after they presented to the ED. The first project was to reduce COPD readmission rates for people who were admitted to the hospital. Here we investigated the system failures and gaps in cares and developed a COPD care bundle and implemented it reliably to improve the outcomes and reduce the readmission rate from 22% to 15%. Then we spread the same practice to the ED observation unit and reduced the ED revisit rate from 49% to 29%. And now we are stuck essentially because we want to improve outcomes further by optimizing the triage mechanism in the ER, which patient is going to have a high chance of admission or readmission, and also want to optimize and predict people who are going to do well in the ED observation unit. But we don't have any data to support that, and we don't have any validated tools. So we now rely on research, conventional clinical research, to develop predictive models and tools to see if we are able to better triage and better assess the risk in the ED observation unit. So this way, our improvement work had optimized the system enough that it was now ripe to do more research to optimize the outcomes further. And this is very true for any work in our clinical space, that we have a system that has wide variation and is uncontrolled. We improve it through standardization and by reliable care delivery and improve the outcomes. And then after that, it actually leads to more innovation, more creativity, and finding new ways to optimize care. So in this way, you can see how improvement science is actually built on known knowledge and clinical research. And once we optimize the systems, then we lead ways to further innovation and further improvement by creating new knowledge. So there's lots of synergy over here. Here are the list of publications that we did throughout these projects that we performed. And I want to emphasize the point that it is equally important and gratifying to publish QI work. So as an academic institute, we need to excel in both of these types of work, improvement plus research.